Hello, everyone. My name is Sabrina Novak, and I'm working with Brody Malone, and we are going to discuss aortic stenosis during emergent hip pinning, status post-fall. So this is just a quick check question for you guys. What are the classic signs of aortic stenosis? Syncope, dyspnea, left ventricular hypertrophy, angina, orthostatic hypotension, pulmonary hypertension. Pick three.
Okay, so for a case presentation, we have a 74-year-old female, 70 kilograms, ASA class 4, with known severe aortic stenosis. Her recent echo had a valve area of zero point 0.7 centimeters squared, the mean gradient of 45 millimeters of mercury, and her EF was preserved. She fell at home and presented with a displaced femoral neck fracture. She's in significant pain, mildly dehydrated, her heart rate is 92 in sinus rhythm, her blood pressure is 148 over 78. Her pulse ox is 95% on room air, and she last ate 4 hours ago. She's intermittently confused, likely from pain meds, in the emergency room. The orthopedic team requests urgent hip pinning. She has no known allergies. Her medical history is significant for GERD, well controlled type 2 diabetes, occasional dyspnea, and severe aortic stenosis. Her surgical history includes an upper endoscopy in 2015 with no complications. For the anesthetic plan, we're going to do a general anesthesia with endotracheal tube, and we're going to use TiVo with propofol. Pre-induction arterial line, BIS monitoring. She already has one large bore IV. We're going to add a second. We're going to do a 5-lead EKG monitoring and SpO2, standard ASA monitors. Induction, we're going to do a modified RSI with 50 mics of fentanyl, 80 milligrams of lidocaine, and 20 milligrams of etomidate with 70 milligrams of succinylcholine and no mask ventilation. So question one, and this is a hotspot question. So you're in the preoperative area and you're ready to examine your next patient who has aortic stenosis. Where would you place your stethoscope to auscultate for this specific valvular disorder?
So in the pre-op area, you were auscultating your patient's heart sounds, and you placed your stethoscope at the right sternal border at the second intercostal space. After that, the preoperative nurse completed an EKG, and as you were about to walk away, she printed the rhythm and she ran over to show it to you. This is what you see. So, based on what you see, should the case be canceled? Should it be delayed? So we decide to delay the case and give 1 liter bolus of LR to optimize preload due to the newer onset of AFib. Um, Question 2A. In aortic stenosis, what percent does the atrial kick contribute to cardiac output? A, 5%, B, 10%, C, 20%, D, 40%. Question 2B. Which two leads monitor ischemia best? Lead 2, lead 3, lead V4, or lead V5?
Okay, so which induction agent is most appropriate for someone with severe AS? Is it etomidate? Is it propofol? Is it ketamine? Or is it thiopental? And here's an open-ended question. So why normally in this case, in a normal, healthy, scheduled procedure, or maybe not a patient with severe AS, you would probably maybe do a spinal anesthetic. So why would you avoid a spinal anesthetic in this patient who has severe aortic stenosis, and why?
Pathophysiology. So the normal aortic valve orifice diameter is between 2.5 and 3.5 centimeters squared. In severe AS, this orifice is less than or equal to 0.8 centimeters squared, and some texts say less than 1 centimeter squared. Some common etiologies for aortic stenosis is bicuspid aortic valve, which is the number one, rheumatic fever, and infective endocarditis. Pharmacokinetics. So, why did we decide to run a TIVA? We decided to run a TIVA on this patient because of the rapid onset and offset of propofol, considering the time needed for this procedure. TIVA is associated with less hemodynamic instability than gas. SIVO has profound vasodilatory effects, especially at 1 Mac and more. We use the BIS to measure adequate depth of anesthesia with goals between 40 to 60 to keep just the right amount of propofol on board. Context sensitive halftime is especially important for emergence. It takes into account how long the drug infusion has been running and the time needed for the drug to redistribute into the peripheries for elimination. This is why it's a good choice for quick hip pinning. So as you can see here in the chart and the yellow, that's propofol. And if the infusion is less than 8 hours, it has a context sensitive halftime of less than 40 minutes. And if you see down there below, if the infusion is about 1 to 2 hours, which is about the time it will take for an average hip pinning, this context sensitive halftime decreases profoundly. So it's probably about 10 to 15 minutes.
So here's the case continued. Your induction does not go smoothly, sadly. During induction, the patient becomes hypotensive. Their blood pressure goes from 148 over 78 to 70 over 40. You see ST segment depression and you note weak pulses. And her heart rate is also 109. So while you're intubating, your attending treats the pressure with phenylephrine. And you also decide to start a phenylephrine infusion afterwards. Why? Question 5. Where is the ischemia likely occurring in this patient? Is it the subendocardium? Is it the epicardium? Is it the myocardium? Or is it the pericardium?
Question 6. What kind of hypertrophy does aortic stenosis cause? A. Concentric hypertrophy with sarcomeres in series in the left ventricle. B. Eccentric hypertrophy with the sarcomeres in series in the right ventricle. C. Concentric hypertrophy with the sarcomeres in parallel in the left ventricle. D. Eccentric hypertrophy with the sarcomeres in series in the left ventricle. Aortic stenosis develops due to an obstruction to forward flow across the aortic valve. Diastolic dysfunction occurs due to filling being impaired. This is considered heart failure with preserved ejection fraction or heart failure PEF because the ventricle is still maintaining the cardiac output. EF is preserved. This is mainly due to the concentric hypertrophy, which is helping out a lot here. So the issue here is the heart has trouble in diastole, it has trouble relaxing. And you can see in the middle picture that the stenosis causes the pressure overload, which then causes the concentric hypertrophy, and the sarcomeres are added in parallel. This is the complete opposite for a regurgitation picture where the sarcomeres will be added in series. And then on the right, you see a normal ventricle where the sarcomeres are just in its normal formation.
So the key takeaway is that LV overload occurs due to increased pressure. So this little diagram is from Apex. So it shows that the pressure is increased, which causes an increase in the end systolic wall stress, which causes parallel replication of sarcomeres, as Sabrina said. It causes wall thickening, which is concentric hypertrophy, and you get HFpEF. So patients with heart failure with preserved ejection fraction, like Sabrina said, have diastolic dysfunction. So it's really important, and that means that changes in preload and heart rate have the ability to significantly impact your filling and your cardiac output. So sinus rhythm and the associated atrial kick should be maintained throughout the procedure in case this should not take place unless emergent, like this case, until sinus rhythm has been restored. And if the patient's in chronic AFib, the rate should be controlled before going to the OR, ideally. And also, these patients have a fine or there's like a fine line for fluid balance with these patients. You want adequate preload, as mentioned above, but you also want to limit the risk of increasing diastolic dysfunction and overwhelming the heart, which can cause a backup of fluid, causing pulmonary venous congestion and pulmonary edema. And for severe heart failure patients, which is patients with an EF less than 25 or less than or equal to 25%, it's often recommended to use intraoperative echocardiogram to look at the LV and monitor for changes in function and fluid management strategies. However, that's not really relevant for this patient because she does have a preserved ejection fraction. So question 7. All the following decrease ventricular wall stress except select 2. So is it decreased radius, B, increased wall thickness, C, increased intraventricular pressure, or D, increased radius?
Oh, I'm so sorry. So the law of Laplace. It illustrates the relationship between wall tension, internal pressure, and radius. So in the left ventricle, we can see wall stress is defined as this calculation. It's intraventricular pressure times the radius in the numerator over 2 times the ventricular thickness. Intraventricular pressure is the force that pushes the heart apart from the inside. Wall stress is the force that holds the heart together. Aortic stenosis increases intraventricular pressure. Therefore, increased thickness is needed to compensate. And so from this equation, you can see that the wall stress is reduced by a reduced intraventricular pressure. This makes sense because if there's less pressure inside the heart, then there will be less wall stress. You can also deduce this relationship because intraventricular pressure and radius is at the numerator. So you know that the relationship is going to be a direct relationship. So this leads us into radius. Again, decreased wall stress will be seen with a decreased radius. And this makes sense because if there's less volume inside the heart with a decreased radius, then there will be less wall stress, as opposed to something with an increased radius, more volume can fill in this increased radius and thus increase wall stress. Increased wall thickness is at the denominator here, so we will see an indirect relationship. So wall stress will be decreased when the wall thickness is increased. And some things we can consider that are in real life when we see in clinical practice is, let's say a patient is in Trendelenburg position. We know that wall stress will be increased because there will be increased volume flowing into the ventricles. Same thing when we give a large, rapid fluid bolus. We will see an increase in wall stress. We will see a decrease in wall stress in a picture where there's cardiac tamponade because there will be less preload coming into the heart. So those are just some real life examples. And question 8. Match each pressure volume loop to the appropriate diagnosis. You want to match aortic stenosis, mitral stenosis, aortic regurg, and mitral regurg.
Okay, so question 9. Which hemodynamic parameters should be maintained for someone with severe aortic stenosis? Um, do you want A, preload low, rhythm, normal sinus rhythm, and SVR normal? Do you want B, preload high, rhythm AFib, SVR high? Do you want C, preload high, rhythm, normal sinus rhythm, SVR as normal? Or do you want D, preload low, rhythm, normal sinus rhythm, and SVR high? Okay, so anesthetic management. So what we classically learn about these patients is you want them full, slow, and constricted. So you want the heart rate to be normal sinus rhythm. Patients don't tolerate tachyarrhythmias, and they also don't tolerate bradyarrhythmias. So tachyarrhythmias prevent adequate filling of the heart chamber and thus decrease the cardiac output. However, in the bradyrhythm, the heart rate slows, the LV becomes overdistended and compresses the subendocardium, which is where the vasculature that supplies the heart resides. And compression of these vessels will decrease blood flow to the heart and thus decrease oxygen supply to the myocardium itself. So you also want to increase preload or at least maintain it. Adequate left ventricular end diastolic pressure is needed to fill the non-compliant left ventricle. You want to maintain contractility. You want to maintain or increase your SVR, which is another reason why etomidate is a good induction agent of choice due to its hemodynamic stability. And you would avoid a spinal anesthetic in these patients. So, a sympathectomy rapidly reduces the SVR and can lead to reduced coronary perfusion pressure and CV collapse. And as we mentioned earlier, patients with AS are preload dependent. So a consequence of regional anesthesia, more so a spinal anesthetic, is loss of sympathetic tone due to the block. And this causes vasodilation in the periphery and lower blood flow back to the heart, which causes preload to drop. And oftentimes we give boluses, ahead of time or during the spinal anesthetic to try to treat and prevent this, but it doesn't really work that well. I'm sure everybody knows from practice. So, a drop in the preload would cause a drop in the blood flow through the heart, and a higher pressure going through the heart is needed to overcome the high afterload seen with AS patients. Additionally, a lowered SVR due to spinal anesthetic would cause coronary perfusion pressure to drop, and you risk coronary ischemia from the combination of lowered SVR and the severe AS limiting blood flow to begin with. And so, as there was a question above that we started a phenylephrine drip and used phenylephrine to treat our pressure. And there's a reason why, and it's because phenylephrine is a pure alpha 1 agonist, meaning it does not have beta properties and does not affect the heart rate directly. However, it can indirectly because of baroreceptor function. It works in the peripheral arteries and the veins to cause vasoconstriction. And this increases the SVR and decreases the heart rate, which is good for someone with severe AS. And also, I just want to touch on, we talked about etomidate being the induction agent of choice, and somebody might say, well, why would you not use, like in heart rooms, we've seen they use a high dose fentanyl and midazolam induction. And the reason we chose not to do that in this case is because, number one, it's a quick procedure, and we worry about using such high dose opioids that it could cause respiratory depression. And additionally, she was already kind of confused in the ER, and we don't want to add to that by giving her more opioids than necessary. Um, and like I say, these are quick cases, so we wouldn't want to have to use Narcan or something like that towards the end. So we believed it was a better choice to use etomidate and minimal opioids to induce this patient.
Question 10. Your patient later undergoes a TAVR procedure. After a successful surgery, you know that her left ventricular end systolic volume will be A, increased, B, decreased, C, unchanged, D, 0. Aortic stenosis treatment. Over time, compensatory mechanisms become maladaptive and they reduce myocardial oxygen supply. So we see a subendocardial compression. So vessels in the subendocardium that feed the larger vessels on the heart, they become compressed when the muscle is hypertrophied. This causes ischemia. It also increases myocardial oxygen consumption due to the increased heart mass, like I said. We see myocardial ischemia, left ventricular failure, and pulmonary edema because of this. Ischemia specifically is best monitored in leads V4, V5, with V4 being the number one lead for ischemia if it's asking for just name one lead. Um, Arrhythmia is best monitored in lead 2. So when we combine these three leads, we get a 96% specificity for ischemia. So that is like the best option possible to monitor for heart ischemia. Aortic valve replacement, open versus TAVR. TAVR is a minimally invasive method. It avoids the bypass pump and it avoids sternotomy. We see a reduction in the LV to AO gradient. This results in less obstruction to flow and therefore a decrease in left ventricular and systolic volume. This makes sense because as there's a less obstruction to flow, there's less resistance for the blood to flow out of the valve. The valve is fixed; it's not stenotic anymore, and therefore the heart is able to pump out that volume more efficiently and there will be less volume left at the end of systole in the heart because it will be pumped through. And this is a last slide that we want to include. It sums up everything we talked about. You see the concentric hypertrophy in the muscle. You see that this increases the risk of subendocardial ischemia. We also see that afterload is fixed at the aortic valve. Okay. And a fun fact that we found is that acquired von Willebrand factor disease occurs in up to 90% of these patients with severe AS. And this is because the von Willebrand factor molecule is damaged and sheared when it passes through the stenotic valve.
And here's our references, and then here's a quick Apex easy find area. So we have Unit 3 and Unit 4 to find what we talked about today. Thank you guys so much.
Thank you so much. Bye.